Morning everyone, welcome to Unacademy, where we have with our top educators quality and content. You all will have a great learning experience with us, and we are going to help you all crack NEET PG exam. So let's crack NEET PG together, guys, at Unacademy. A little about me: I've done my MBBS from Father Muller Medical College, Mangalore, my MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. So today's topic, I'm sorry, it's not local anesthetic, it is peripheral nerve blocks. We will be dealing with peripheral nerve blocks. I think there was some problem with the editing there, and we'll be dealing in detail with the peripheral nerve blocks. So a little about Unacademy now. It's one of India's largest learning online platform where you get plus subscription and you have access to unlimited live and recorded courses from India's best educators. The educators have researched and structured the courses so that it will be to your advantage. So what will you get out of Unacademy? So we have our daily life classes. Basically, when you go to a coaching class, of course they are live classes, but you have to travel, you have to spend your energy, you have to spend your time. By the time you get there, you have to, if you don't get a proper seating arrangement, then you have to see to that. You have to it's not easy for your educator. These are large classes, right? It's not easy for your educator to pick out each one of you all and clear all your doubts. So maybe all your doubts won't be cleared. So there are lots of ups and downs, okay? But over here on Unacademy, you can chat with your educator, engage in discussion, clear your doubts, and answer polls. And all this is while the class is going on. Your educator is there to help you. Your educator will clear your doubts then and there. So guys, please subscribe. Let us help you all crack this exam. It's not too far off, and we are here to help you all. These are structured courses. All our courses are structured in line with your exam syllabus, and we are here to help you best prepare for it. We conduct live tests and quizzes by which you can evaluate your preparation and get a detailed analysis on your performance. So we conduct based on the topics that we teach, we shall conduct the quizzes, and you all can evaluate your preparation based on this. And then of course there's unlimited access. A one-time subscription gets you access to all our live and recorded courses, and all this is to watch from the comfort of any of your devices while you all are sitting at home. So wherever you all may be, whether you all are on your honeymoon or whether you all are traveling or whatever it is, you all can still keep out a few hours per day with us and prepare, and we are here to help you all crack this exam, and let's do it together. These are some of our top educators: Dr. Nikita Nanwani, Mohammad Azam, Dr. Preeti Sharma, Dr. Devesh Mishra. Dr. Nikita Nanwani is a PG mentor for radiology as well as mnemonic and concept, focusing on most known topics encompassing almost all the subjects, right? And so these are some of our courses offered. Now, like you can see, there are like approximately 19 subjects out here, and they're vast subjects. These are MBBS topics. You all know that these are not small topics. Some are not even covered in detail in MBBS, like anesthesia. It's just like a 15-day posting or something like that, and you learn a little bit, and you run off half the time, you don't attend, even during internship. So these are an anesthesia vast topics. So, and it's a lot. It's some 11 points, and they can ask you those 11 points from anywhere in the subject. But it's a scoring subject. It's a scoring subject like your ophthal, psychiatry, radio, ortho. All these smaller subjects are very scoring. So don't leave them out. Cover them so that you all score here. These small subjects, it makes up like your physiology, anatomy, and all. I'm not saying don't study it. You have to, because they have maximum marks. But then don't miss out on these smaller subjects, because then your score comes down. So that's why we're here to help you. You all don't have to go really that much in depth in these subjects, but you all need to know most things, and we are here to help you cover those topics. And there are different courses offered under each, as you all can see. These are some of the ongoing courses on our platform. As you can see, a course on neurophysiology, GI surgery, cardiovascular thoracic surgery, and pathology, respiratory system, a capsule on larynx are of various courses. Now coming to the subscription, as you can see on the screen, there are 5 types of subscription. Now I would highly recommend that you all go for the 12 and the 24-month subscriptions. Now quite frankly, we just saw that we have 19 subjects to cover. Those are not small topics. There's such vast topics, so much to cover, so much to uh, finish off in that short period of time, right? It is a little difficult. It is quite difficult, rather, not little difficult. So quite frankly, 1, 3, and 6 months is a short time. I don't think it is possible to cover so many subjects in 6 months. It's not impossible, but it is a little difficult if you ask me to cover these topics in 6 months. But a 12 and a 24-month subscription is ideal. You have your time, you can prepare in a structured manner, you go about it in a structured manner. It's all right there for you. So I would recommend that you go for these two subscriptions. And also, you have time to go. It's knowledge at the end of the day. You have your time to sit and get to know these subjects. You will know what you want to choose when you are studying these subjects. You might have chosen something in your mind, but that might not be actually what you want. So when you are actually studying these subjects, that's when you realize, oh, I kind of like this subject, maybe I should take this subject up. So it actually helps when you are spending that time with your books and reading for the entrance exam. So as you can see, use my code at the bottom of the screen, SASHA in red, it's written, and you can avail a 10% discount. Okay, if you use my code, you'll avail a 10%, you'll avail a 10% discount. Now your 1, 3, and 6 months, again it's economical. This 12 and the 24-month things are pretty economical because um because it's a one-time subscription, right? After 6 months you'll have to subscribe again, and then come on, you cannot go on like keep paying, right? I know it is kind of difficult. So it is a little difficult to come on, I mean, pay again. And but with your 12 and 24 months you have that time frame, so it is more economical too if you look at it. Again, 24-month subscription. It's not everyone's cup of tea to clear in 1 year. No problem, take 2 years. You lose nothing. You will only gain because you are learning at the end of the day. No harm. It at the end, later on in life, it's not going to come back and bite you saying that you lost 2 years. Oh my God, you could have done this. Nothing like that. It's still it's your comfort. It's your satisfaction. You can take it. There's nothing wrong. Now we'll come to our topic for today, which is the peripheral nerve blocks. So, firstly, the cervical plexus. Okay, the cervical plexus represents nerves from the anterior rami of C1 to C4. So, as you can see, anterior rami C1, 2, 3, 4. Okay, and 4 primary branches: a lesser occipital nerve, greater auricular nerve, supraclavicular the supraclavicular nerve, that is coming from your C3, and your transverse cervical nerve. Okay, these are the superficial branches. So we have 4 superficial primary branches: lesser occipital nerve, greater auricular nerve, supraclavicular nerve, and transverse cervical nerve. Then coming to your the uh, deep branches. So they primarily muscular innervation. So the deep branch has primarily a muscular innervation. Superficial are the basically the greater auricular behind the ear and all that. It's more skin oriented. So the deep is C1 innervates thyrohyoid and genohyoid muscles. thyrohyoid and genohyoid muscles. The ansa cervicalis, that is your C1. So basically C1 and your C3, they form a loop and known as ansa cervicalis. This is important. This ansa cervicalis, what it is, C1 and C3 loop is ansa cervicalis. It innervates the sternohyoid, omohyoid, sternothyroid. So sternohyoid, omohyoid, and sternothyroid. So and then of course we have the segmental branches which innervate the scalene muscles, and the phrenic nerve C3 C5 innervates the diaphragm and the pericardium. So this nerve is very important. This is one of the phrenic nerve palsies. So it is an important nerve during neurosurgery of the cervical region. So we have a under the cervical plexus we have a superficial and deep branches. The superficial have four primary branches, that is your lesser occipital, greater auricular, supraclavicular nerve, and your transverse cervical nerve, right? And the deep primarily has muscular innervation, and C1 innervates. So first of all, cervical plexus, anterior rami of C1 to C4. C1 innervates thyrohyoid, genohyoid. The ansa cervicalis, which is a loop of C1 and C3, will innervate your thyrohyoid, omohyoid, sternothyroid. And then we have the phrenic nerve, which is C3 and C5, which innervates the diaphragm and pericardium. Now the lesser occipital, no, that is the superficial branch of the cervical plexus. So as you can see in the diagram here, we'll trace the over here, as you can see, the lesser occipital, that is right here, coming from your C2. So your superficial branches are coming from your C2 and C3. So as you can see over here, here is your lesser occipital nerve. So it arises primarily from C2 with some branches from C3. Here, as you can see, this is your nerve, okay, and it innervates the posterior lateral aspect of the scalp along with greater auricular and provides sensation to the posterior aspect of the ear. So it goes behind the ear. This is your ear here. So it goes behind the ear, provides sensation to the, again, this is a superficial branch, so it provides sensation to the posterior aspect of the ear, and it innervates the posterior and lateral aspect of the, because this is behind the ear, right? So posterior and lateral aspect of the scalp along with the greater auricular nerve. Now your greater auricular nerve, as you can see over here, this is your greater auricular nerve. It's coming from your C2 and C3 primarily. So arises from C2 and C3. Anterior branch, so we have a greater auricular nerve is here. The anterior branch innervates the skin. This is your greater auricular nerve. Your anterior branch innervates the skin, supplying the anterior aspect of the ear and the skin over the parotid. So this is your anterior branch. So it will supply the anterior aspect of the ear. And so guys, this is quite easy. The thing is, if you know where they arise from and how they distribute, it's quite easy in your exam, in your MCQs, to remember how to go about it. But just that you need to, so this is where the anatomy plays in anesthesia. So anesthesia basically encompasses everything: anatomy, physiology. It has some amount of biochemistry too. It has obstetrics, pediatrics, medicine, everything encompassed in it. So like recently I did a class on myasthenia gravis just yesterday on the special class platform. So it encompasses everything. So like you can see the anterior branch, it innervates the skin supplying the anterior surface of the ear and the skin overlying the parotid gland. The posterior branch innervates the skin overlying the mastoid process and posterior aspect of the ear. So this is your mastoid, so this is your posterior branch. This is your posterior branch. The anterior aspect supplies the skin over the parotid gland, skin surface over the parotid gland and the anterior aspect of the ear. The posterior branch innervates the skin which overlies the mastoid process and the posterior aspect of the ear. Now the supraclavicular nerve, it arises from, supraclavicular nerve arises from C3 and C4. So your supraclavicular, see here, C3 and C4. So this is your supraclavicular nerve. So the supraclavicular nerve arises from C3 to C4. The medial branch, here is your supraclavicular nerve. Okay. The medial branch innervates the skin and clavicle from sternoclavicular joint to mid-clavicle. So from the sternum, that is your sternum and your clavicle, where they meet, the sternoclavicular joint to the midpoint of the clavicle is innervated by the medial branch, and the intermediate branch innervates clavicle and skin from the superior aspect of pectoralis major out to anterior deltoid. So that will be below the clavicle. So the clavicle, skin from the superior aspect of pectoralis major to the deltoid, that is to the shoulder, and the lateral branch will innervate the distal clavicle and skin supplying the superior and posterior aspect of the deltoid. So basically this part is covered, right? So this is your clavicle. So your medial branch will innervate the skin and the clavicle from the sternoclavicular joint, that is here your sternum and your clavicle joint, up to the midpoint of the clavicle. That will be your medial branch. Or intermediate branch will innervate the skin from the superior aspect of the pectoralis major and out to the anterior deltoid, which will be this part below the clavicle, and the lateral branch will innervate the distal clavicle, the distal part of the clavicle, and the skin that covers the superior and posterior, basically the superior and posterior parts of the deltoid, this part. So that's what is covered by your this portion. Basically the skin is covered by the supraclavicular nerve. Now your transverse cervical nerve. This is your transverse cervical nerve, basically coming from C3, arises from C2, C3. So none of these nerves really come from a single nerve root. They will always have 2 or 3 additions. So it arises from C2, C3, and it provides cutaneous and deep innervation. So we have a transverse cervical nerve here, coming down like this. Okay, and it provides cutaneous and deep innervation to the anterior, medial and posterior lateral aspects of the neck. So anterior, the medial, so the anterior aspect, the medial aspect, and the posterior lateral aspects of the neck. So basically the skin over here, this part of the neck, is covered by transverse cervical nerve. So how would you go about, now that you know the, now that we know the anatomy of each of these superficial nerves? Okay, so basically what were the nerves we did? The transverse cervical nerve, greater auricular nerve, supraclavicular nerve, and lesser occipital nerve. So how would you go about blocking this cervical plexus? So basically a standard regional anesthesia tray is prepared with the following equipment. So this has to be there in general. It has to be sterile. So you have to have sterile towels and gauze pieces. You have to wash your hand with the hand hygiene. You have to perform hand hygiene basically, with the 9 steps that are allotted to hand hygiene, and a 20 ml. Then you have to wear sterile gloves, have to be drawn. After that, a 20 ml syringe with local anesthetic. So this is the dose. It is a superficial block, so 20 ml, and because there are multiple nerves to be covered, as a result, we would take a higher volume of a local anesthetic. Now, when choosing your local anesthetic also, uh, that's when we have to choose a local anesthetic with a lesser concentration. We have to dilute the local anesthetic because we are giving a high volume of the drug, which can lead to local anesthetic toxicity. So accordingly, the local anesthetic has to be chosen. Like probably we could mix we could take 10 ml of lignocaine plus adrenaline, because it will act rapidly and there will be lesser absorption into the arterial supply because of adrenaline. And then we could add a longer acting, like maybe another 10 ml of 0.25% bupivacaine, because the idea of this block is to provide analgesia and not motor blockage. So we can use 0.25%. 0.5% bupivacaine is more for motor blockade. A 25 gauge needle, sterile gloves, and a marking pen to mark your anatomy. So the patient positioning and landmark. So the patient is positioned in a supine semi-sitting position with the head facing away from the side to be blocked, obviously. So semi-recumbent position, semi-sitting and supine, the patient is positioned with the head away from the side of the block. So the surface landmarks for the superficial cervical plexus block are: one is your mastoid process, which is behind your ear; the transverse process of C6 vertebrae. Needle insertion is at the midpoint between C6 and the mastoid process, behind the posterior border of the sternocleidomastoid. So basically your C6, you have to palpate your C6, that is the most prominent thing at the back of your neck, and your mastoid process, the midpoint of it is the point for your needle insertion, and it corresponds to the posterior border of the sternocleidomastoid. So after cleaning the skin with an antiseptic solution, the needle is inserted along the posterior border of the sternocleidomastoid, and 3 injections each of 5 ml are injected behind the posterior border of the sternocleidomastoid subcutaneously. Okay, so you, with one single prick, you have to go perpendicular. So first you enter perpendicularly. So if this is the patient's head, I'm sorry, whatever. Okay, this is your patient's head. So your mastoid process is here. So the midpoint, your sternocleido will come somewhere here. So basically you enter perpendicular with your needle. At the same entry point, you direct it cephalad and you direct it caudal. Okay, so that's how you give 5 ml as soon as you enter perpendicular, 5 ml subcutaneously. When you go, then you direct it the cephalad means towards the head, you give 5 ml, and you develop with caudal and you give 5 ml all subcutaneously, and this will come in a fan shape because your drug will come distributed like this. So this is a fan shape distribution. See here, so this is how it is marked. This is your, this will be your entry points, the midpoint of between your mastoid process and your transverse process of C6. So the midpoint of that behind the posterior border of the sternocleidomastoid, that is your sternocleidomastoid. This is Basically, this is your sternocleidomastoid. This outer leg. Sorry, this is your sternocleidomastoid. Okay, so this is the behind the sternocleidomastoid, the midpoint of that line. Okay, so you go in perpendicularly, then you go cephalad, and then you go caudate. 5 mm, 5 mm, 5 mm. Okay, this is the ultrasound image, how it is seen. That is not necessary for you all right now, but yeah. So the deep cervical plexus block. So now we need to, now these are the muscles. Okay, the deep block, like we studied, these are muscular innervations. So they were covering the ansa cervicalis C1 C3 loop innervated the sternohyoid, omohyoid, sternothyroid. C1 innervated the thyrohyoid and genohyoid, and of course your C3 C5 was innervating the diaphragm and the pericardium. So these are your deep nerves. So let's see what we are going to block. So your deep cervical plexus block, the position is sitting, supine or sitting. Again, mastoid process and your Chissigne tubercle. 3 to 4 ml is injected at C2, C3, C4. Okay, so 3 to 4 ml is injected at C2, C3, C4 vertebrae. The block is performed using a paresthesia eliciting technique to observe a paravertebral block of C2 to C4. So basically the patient is asked if he is feeling any paresthesias, any tingling, and that's how the block is performed. Don't perform this because again a little dangerous, and so this is performed to obtain a paravertebral block of C2 to C4. So we'll come to that. As you can see, so the needle, as you can see in the diagram, C2, C3, C4, and by so the common carotid artery is just there, and by palpating the Chissigne tubercle and the mastoid. So the landmarks are the patient is placed in the same position, that is semi-recumbent position for the superficial cervical plexus block. So all these are important. They can ask what is the position and all. The three landmarks for deep cervical plexus block are similar to those for the superficial block. So the landmarks are kind of similar, what we discussed. And what were those landmarks? We discussed that behind the posterior border of sternocleidomastoid and the midpoint between the mastoid and the C6 vertebrae, that is your Chissigne tubercle. The midpoint and at the posterior border of the sternocleidomastoid, the needle will be inserted. But this is a deep block, so the needle has to go deeper. So to estimate the line of needle insertion, overlying the transverse processes, the mastoid process and the transverse process of C6 are identified and marked. So the three needle points in the superficial cervical plexus block, it was one needle point in a fan-shaped manner that it went. But over here, three separate insertions are needed. And to estimate where the needle is inserted, one is over the transverse processes, the mastoid process. So the line of insertion overlying the whichever line of insertion, the line that overlies the transverse process, the mastoid process and the transverse process of C6. So it's a line that is drawn like here in this diagram. So the line that is drawn overlying the transverse process, these are the transverse processes. So the line is drawn like that. So it has to overlie the transverse process, the mastoid process and the transverse process of C6. The latter is easily palpated behind the clavicular head of the sternocleidomastoid. So the C6 process is easily palpated behind the clavicular head of the sternocleidomastoid, just below the level of cricoid cartilage. Okay. So behind the clavicular head of the sternocleidomastoid, just below the level of the cricoid cartilage. Next, a line is drawn which will connect the mastoid process to the C6 transverse process. The palpating hand is best positioned behind the posterior border of the sternocleidomastoid muscle. So behind the sternocleidomastoid muscle, and once the line is drawn, the insertion sites must cover C2 through C4, labeled as C2 2M corded. C2 is located 2M below the mastoid process, C3 is 4 centimeter below the mastoid process, and C4 is 6 centimeter below the mastoid process. So this is how, so basically once the line is drawn, so the clavicular head and where your cricoid insertion, your C6, you get approximately like that. As you can see, the insertion of the clavicular head and where you're just below your cricoid. So your cricoid will come over here. Your cricoid comes here. The most cricoid is just below your hyoid bone. The most prominent part is your hyoid. Just below your hyoid is your cricoid, and where the sternocleidomastoid, the clavicular head attaches, and here this. So here will be your cricoid. So this will be around C6. So you draw a line from the mastoid process to C6 like this, and then 2 centimeters, 4 centimeters, and 6 centimeters, like we just did. So your C2 is 2 centimeter chordate the mastoid process. So C2 is 2 centimeters caudal to the mastoid process, C3 is 4 centimeters caudal to the mastoid process, and C4 is 6 centimeters caudal to the mastoid process. So C2, C3, C4 will be blocked by measuring. Okay, so you basically, the line has to be got, the position is similar, the landmarks are also similar to the superficial cervical plexus block. So now we've covered our deep and superficial cervical plexus block. Now when are these blocks used? During carotid end arterectomy, lymph node dissections, and plastic repairs of the neck, and during thyroid surgery. Not commonly used, but they can be used. Now stellate ganglion block. Now a little about the anatomy of stellate ganglion. It is a sympathetic ganglion that is situated on either side of the root of the neck. It is formed on each side of the neck by the fusion of the inferior cervical ganglion with the first and occasionally second thoracic ganglion. So the stellate ganglion is a combination of inferior cervical ganglion and your first and sometimes second thoracic ganglion. Also, it is supplied, the ganglion is only supplied by the sympathetic fibers from the same side of the sympathetic chain which lies inferior to it, along with the first and second thoracic segmental anterior rami. So as you can see, this is your stellate ganglion. Root of the neck, it's located. Your sympathetic chain lies posterior, and it is formed by the rami of that side of the sympathetic chain, and T1, whatever T1 and T1 but second and first, but occasionally second thoracic ganglion contribution. So the anatomical relations are: anteriorly you have subcutaneous tissue, sternocleidomastoid muscle, subclavian artery, and your carotid sheath. You have your subclavian artery, you have your carotid artery sheath, your sternocleidomastoid muscle. Okay. Posteriorly is your anterior scalene muscle, brachial plexus sheath, neck of the first strip, transverse process of C7, vertebral artery, and longus coeliac muscle. So you have your, these are anterior and posteriorly, you have your anterior. So I got this cervical plexus block, actually the stellate ganglion block, from my university exams when I gave my post graduation. And yeah, we always get one block for our exam, so we have to know these things, even whether we perform it or not. So anterior scalene muscle, sheath of the brachial plexus, neck of first rib, transverse process of C7, vertebral artery, and longus coeli. Laterally, you have your superior intercostal vein, superior intercostal artery, ventral ramus of first thoracic nerve, and medially you have your prevertebral fascia, vertebral body of C7, esophagus and thoracic duct. So the anatomical, oh, I'm sorry, I mistake that. The anatomical relations are vascular disorders of upper limb like Raynaud's phenomena, obliterative vascular disease, vasospasm, scleroderma, trauma, embolic phenomena, frostbites. These are some of the contraindications are recent MI, because they are so close to the major arterial supplies. So recent MI, anticoagulate patients or those with coagulopathy, anyways, blocks cannot be performed in such patients because they're very close to arteries, and of course a repeated needle puncture, if punctures arteries, can lead to bleeding. Glaucoma and any pre-existing contralateral phrenic nerve palsy may precipitate respiratory distress if both sides of phrenic nerves get blocked. So the technique is basically the patient is in a supine position. So the patient will be in a supine position with slight extension of the neck. Okay, the head is turned to the opposite side. The needle is introduced between the trachea and the carotid sheath. So you palpate the carotid and the trachea. You introduce at the between the trachea and the carotid sheath at the level of the cricoid cartilage and Chisegnac's tubercle, that is your C6 vertebrae, to avoid any potential injury to the pleura. But it is still dangerous because one side is your carotid, one side is your trachea. So between the two, at the level of the cricoid and the C6 tubercle, the sternocleidomastoid and carotid artery are pushed away. So you have to palpate the carotid artery and it is pushed away like that, are pushed away, while simultaneously palpating the deep will be your C6 tubercle. So the skin and the subcutaneous tissue are pressed firmly onto the tubercle. The needle is directed medially. So the skin and the subcutaneous tissue are pressed firmly onto the tubercle. The needle is directed medially and inferiorly towards the body of C6 to hit it, and then you withdraw it 1 to 2 mm to rest outside the longus coeli. So always the methods in giving block is, if you're giving a blind block which is not ultrasound guided, where you cannot measure the depth, you enter to hit the bone, withdraw and then inject your drug. Okay, that is your landmark that you have hit bone. Okay, fine, you're safe. Withdraw, inject. So the subcutaneous tissue and skin are firmly pressed onto the tubercle. The needle is directed, it has to go medially and inferiorly, okay, towards the body of C6. You hit the bone, withdraw 1 to 2 mm and that will rest outside your longus coeli muscle. Again, here less amount will be given because it is, again, there is a lot of arterial supply. So 10 mm of 0.25% L-bupivacaine, a lesser dose is given. After a small test dose of 0.5 ml and negative aspiration for blood to rule out intravascular placement. So this is very important in every block. Before giving the local anesthetic, negative aspiration has to be ascertained, because otherwise it can lead into intra-arterial injection of the local anesthetic and the complications that we have discussed during that class. Basically, it can lead to CNS and the cardiovascular complications. So a lesser dose is given because it is very close to the arteries and it is a small area that needs to be blocked. So we do not need that much of a dose. 0.25% levobupivacaine and 0.5 ml first test dose is given after negative aspiration to just see if the patient, just in case, develops some respiratory distress. Okay, so pain specialist use bupivacaine 0.125 to 0.5%. This is 0.125 is again a low dose. 0.5% if they are using, they will use a very small quantity, or ropivacaine 0.2% in a volume ranging to 5 to 15 ml depending on the approach for the block. Okay, local guidelines and protocols and clinical management. So depending on how they are approaching the block, protocols and whatever clinical, so that's very important, the clinical judgment, they will decide on the concentration of the drug and the amount of the drug to be given. So patient in supine position with head extended, you palpate the, palpate the sternocleidomastoid and the carotid artery, move it to one side, go deep, feel your C6 tubercle, enter between the trachea and the carotid artery. That is your point of entry. All the major are the CT or ultrasound. Line blocks in these deep block cases are generally not advised because it can be very dangerous. So it is advisable that, you know, ultrasound guided and CT guided these blocks are performed, which can be safer for the patient, right? So so again, like I said, patient in supine position with the slight extension of the neck. So after cleaning and draping the site, the transducer is so after cleaning and draping the site, so the site has to be cleaned and draped with betadine and spirit. Transducer also should be cleaned. The ultrasound, it is a sterile procedure, so everything transducer also has to be wiped down with spirit or hypochlorite. The transducer is placed on the neck at the level of C6 to enable cross-sectional visualization of anatomical structures. At this level, the carotid artery, internal jugular vein, thyroid gland, trachea, longus coeli muscle, root of C6 and transverse process of C6 are identified. So when you keep the transducer at the level of C6, these are what we can identify, that is the carotid artery, internal jugular vein, thyroid gland, the trachea, longus coeli muscle, root of C6 and transverse process of C6. So all these will be identified. Then to retract the carotid and artery laterally and to position the transducer close to the longus coeli, the transducer is gently pressed between the carotid artery and the trachea. So basically the carotid artery should be retracted, the transducer is placed and it is pressed gently between the carotid and the trachea. Then you have to use an in-plane approach, that is in line with the ultrasound probe, the way you have placed it. A 1-inch 25 gauge long bevel needle is inserted paratracheally around the trachea towards the middle of the longus coeli, and after negative aspiration for blood or CSF, because it can go into the spinal space also, local anesthetic is injected and visualized spreading it and is visualized spreading. Okay, so this is your longus. This is your thyroid. Carotid artery. Longus coeli muscle. And this is your sternocleidomastoid. So this is the patient sleeping like this. Yeah, the patient's head is here. Patient's head will be here. This is his sternocleidomastoid. This will be the carotid artery. So you place the probe here. Trachea will be here. So you, the trachea will be. You place the probe between the trachea and the carotid artery. You see your thyroid. This is your longus coeli muscle, and this is your. You have to rest the needle just above the longus coeli. Now complications. Most common is Horner's syndrome, which is caused by sympathetic blockade and produces the following fluids on one side, ipsilateral, the side of the block. wherever it is given, ipsilateral side of the face. There can be ptosis, drooping of the eyelid, meiosis, constriction of the pupil, uh, anhidrosis, that is increased sweating on the same side of the face, redness of the conjunctiva of the eye, and enophthalmos. Because so these are the features of Horner syndrome. This is very important. MCQ, it can be asked from medicine point of view, anatomy. Ptosis, meiosis, anhidrosis, red conjunctiva, enophthalmos, okay. So we have you have your ptosis, your meiosis, your anhidrosis, redness of conjunctiva, and enophthalmos. Ptosis is your drooping of the eyelids, meiosis is your constriction of the pupil, anhidrosis is decreased sweating on the same side of the face, redness of conjunctiva, and enophthalmos, that is apparently a sunken eyeball. So although it may be considered a complication, the presence of Horner syndrome is a confirmatory sign of successful stellate ganglion block. So actually it is a complication, but if that means it's a, and Horner syndrome is it settles by itself. So as such, I mean, it is a complication, but it's sure short that the stellate ganglion block has been successful. So misplaced needle puncturing important adjacent structures, which can be vascular, the carotid artery, which or subclavian artery, which may lead to a local hematoma or hemothorax, carotid artery puncture, internal jugular vein puncture. That is the puncture of these structures, which can lead to a hematoma or a hemothorax. Inferior thyroid artery puncture during ultrasound guided approach. So all these arteries can get punctured. Even this is important. So which are the arteries that can get punctured during a stellate ganglion block is carotid artery, internal jugular vein, which all vascular structure. Sorry, carotid artery, internal jugular vein, inferior thyroid artery. Neurological, they can be vagus nerve injury, brachial plexus root injury, and various other injuries can be pulmonary injury, pneumothorax, chylothorax, esophageal. So all these structures are around the site. So they can be esophageal injury, thoracic duct injury, pneumothorax because of pleura injury, pulmonary injury, brachial plexus lies posteriorly, so brachial plexus root injury, vagus nerve injury are various neurological complications. Now, complications related to the spread of local anesthetic. So, intravascular injection into the carotid artery, vertebral artery, or internal jugular vein, or inferior thyroid artery, uh, brachial plexus spread, localized spread. There can be hoarseness due to recurrent laryngeal, then phrenic nerve blockade. So, because of the excessive local anesthetic, so again you'll have breathlessness here. With intravascular injection, you will have complications. First, the CNS complications, dizziness, disorientation. Initially, there'll be an excitation of seizures followed by respiratory coma. And then you can have, if it is bupivacaine, it is highly cardiosensitive, so it can cause arrhythmias and cardiac arrest, which will be resistant to all the drugs, to CPR and all the drugs that resuscitate cardiac arrest. So these are the complications that can be related to local anesthetic. So then, like I said, local anesthetic toxicity. So you can have your manifested circumoral tingling numbness, which can that is your initial part. Then it can progress to your CNS complications like seizures and finally respiratory arrest. So infection, soft tissue abscess, meningitis, osteitis, because you're giving it around that area, so any infection can lead to soft tissue abscess, meningitis, and osteitis. Now coming to the celiac plexus block, this is again a block. Celiac plexus is known as the solar plexus. It's the main junction of the autonomic nerves supplying the upper abdominal organs like the So this block is basically given in pancreatic cancers because of the severe pain. So it is like a therapeutic block, a palliative block. Okay, so it's not therapeutic. It does not improve the cancer to any extent. It's more palliation. So it is the main junction for autonomic nerves supplying the upper abdominal organs like the liver, gallbladder, spleen, stomach, pancreas, kidneys, small bowel, and 2/3 of large bowel. Now this is important. So all the autonomic nerves supplying these organs like the liver, gallbladder, spleen, stomach, pancreas, kidney, small bowel, and 2/3 of large bowel. Basically, almost all your internal abdominal organs except the 1/3 of the large bowel. Now, the celiac plexus consists of the celiac ganglia with a network of interconnecting fibers. So, the plexus basically has a celiac ganglia. The ganglia lie on each side of L1. The aorta lies posteriorly, the pancreas anteriorly, and inferior cava laterally. So posterior is your aorta. These are important relations. Anterior is your pancreas, and your lateral is your inferior vena cava. Okay. So laterally is your inferior vena cava, anteriorly is your pancreas, and posteriorly is your aorta. And it is made up of the celiac ganglia. Now the celiac plexus block, sympathetic supply is the greater splanchnic nerves T5, T6 to T9 to T10. So T5, T6 to T9 to T10. This is your greater splanchnic nerve, and lesser splanchnic is T10 to T11. That is the sympathetic supply. The upper abdominal organs receive their parasympathetic supply from the left and right vagal drums, which pass through the celiac plexus but do not connect there. So the sympathetic supply connects of these organs go into the celiac plexus, which is formed by your greater splanchnic nerve T5 bar T6 to T9 to T10, and your lesser splanchnic nerve, which is the nerve root is T10 T11. So these organs also get the parasympathetic supply from either side of the vagus, the right and left vagal trunks, but though it passes through the celiac plexus, there is no connections. This block is used using CT or X-ray screening. It is very difficult. You cannot do it blind. And under intravenous sedation or local anesthetic infiltration of the superficial layers with the patient in prone position. So the patient in this, the position in the celiac plexus block is again an important MCQ. The patient is prone, not supine. Patient is lying on his or her stomach, not on the back. So first anesthesia is given for the local area, superficial areas. The intravenous fluids are required pre-block to reduce the risk of hypotension after the procedure, which can occur because it's a sympathetic blockade. It normally takes 2 needle insertions, one on each side, to block both the celiac ganglia, but on some patients, good spread to both sides can be achieved with 1 needle. Otherwise, both sides on each side, needle insertions are needed. The needle entry point is just below the tip of the 12th rib. So just below the tip of the 12th rib, and using X-ray screening in 2 planes, the needle is advanced until it hits the side of L1 vertebrae. So again, below the 12th rib, you always go below the rib, right? Because the nerve bundles are on the upper part of the rib. So always the entry point when it comes to ribs is below the rib. So below the 12th rib, hit the L1 vertebrae, withdraw a little, inject. So as you can see here, this is your 12th rib. So below the 12th rib, and go and hit your L1 vertebrae. So 2 needle insertions might be needed from either side. Prone position, your 12th rib outline, and hitting the lumbar L1 lumbar spine. The needle is withdrawn slightly and then redirected forward until in the area of the celiac plexus. So after it hits the L1 vertebrae, withdrawn slightly, directed slightly forward, avoiding aorta and inferior vena cava. Then radio-opaque dye is injected to confirm the correct placement of the needle, and then only the appropriate mixture is injected. So for non-malignant pain, generally 10 ml of 0.5% sirocaine on each side, and for malignant pain 5 ml of aqueous 6% aqueous phenol plus 5 ml of 0.5% sirocaine on each side. So as the block causes dilatation of the upper abdominal vessels, venous pooling can occur, sympathetic blockade, right? So leading to hypotension. This can be exacerbated by pre-existing hydration, as that is why the need for IV hydration before performing the block is needed. Okay, this is another important point for you all to remember. So some of the complications are, it can severe hypotension even after unilateral block, again because there is dilatation of the upper abdominal vessels, venous pooling can occur, which can lead to hypotension. Then bleeding due to aorta or inferior vena cava injury by the needle. So if the inferior vena cava or aorta get punctured, it can lead to bleeding. Intravascular injection of the local anesthetic can occur, and any abdominal puncture, organ puncture, can form an abscess or a cyst. So the main complications basically are bleeding because of injury to the major vessels, hypotension because of the sympathetic block, and also there's dilatation, venous pooling, then intravascular injection of the local anesthetic, and any abdominal puncture. So basically it's all related to the anatomical structures around the block that your indications and complications come into play. So paraplegia from injecting phenol into the arteries that supply the spinal cord. This can occur because phenol will cause paraplegia when inserted into the spinal cord. Sexual dysfunction, again because you're around that all the plexuses. Lumbar nerve root injection, the injected solution can track towards the lumbar plexus and cause paresthesias. So guys, that was about the blocks for today. We covered the superficial deep cervical plexus block, the stellate ganglion block, and the celiac plexus block. So the superficial cervical plexus block as such is it is a superficial block, and we have to cover, based on the anatomy that you have to cover each of the nerve roots will be blocked. The deep cervical plexus block, again for thyroid surgeries and all is performed. The landmarks and the positioning are similar in the superficial and the deep cervical plexus block. That is, the patient lies supine, turns head to one side, and the sternocleidomastoid C6 vertebrae and the mastoid process are the landmarks for the insertion of the needle. And accordingly, the dose, superficial or deep, the dose of the anesthetic can be given. Superficial plexus, you're injecting subcutaneously, and deep, a lesser dose has to be used because the needle will be going deeper into the structure. So accordingly, the dose of local anesthetic will be adjusted. Then of course we have your stellate ganglion block. It is ideally performed ultrasound guided or CT guided because it is a very deep block, very dangerous block, located along, dangerous in the sense because it is located around all the major structures in the neck. So it can be a little dicey to give this block. As a result, infiltration, it is better when it is ultrasound guided, when you can see the structures like the trachea, the carotid artery, the probe is pressed between them, and the carotid artery has to be moved along with the sternocleidomastoid to one side. Then the probe is pressed till you hit basically till you, it is palpation wise you have to press till you hit C6 tubercle, and then that's the point of insertion of needle between the trachea and your carotid artery. And till the longest, you have to go till you hit the C6 vertebrae and withdraw. That means your needle will be above the longest colline muscle. And on the ultrasound, you will see your thyroid also. Then you inject the desired amount of drug over there. Again, the amount of drug has to be taken into consideration based on the clinical factors and all that. Once your drug is injected, then basically Horner's syndrome, when it presents, it is a complication. It's made up of ptosis, anhidrosis, meiosis, the redness of the conjunctiva, and it is a short indication that your block has acted. And of course, in that area there can be damage to a lot of the major arteries, so care has to be taken. The celiac plexus block, again, all the sympathetic fibers of all the abdominal organs meet in this ganglion, and We are blocking this basically palliatively, pancreatic cancer especially. So all the abdominal organs except the 1/3 of the large intestine the sympathetic supplies from the celiac ganglion. So blocking this will alleviate